Hey y'all, it's Dr. Atkinson. Today we're diving into hemorrhagic stroke. And trust me, this is one of those topics that can feel intimidating until you break it down into what's really happening inside that brain of ours. A hemorrhagic stroke is exactly what it sounds like. Bleeding where there should not be bleeding. That bleeding can leak into the brain tissue, the ventricles, or the subarachnoid space. In nursing school, we love categories, so here's how it breaks down. We've got intracerebral hemorrhage, where the bleeding is actually inside the brain tissue itself. Then there's subarachnoid hemorrhage, where the bleeding is in that space between the brain and the thin tissues covering it. Both are dangerous, both need quick action, but they can have different causes and treatment approaches. Surgical management. Now here's the thing. Not every hemorrhagic stroke goes to surgery, but if a patient is getting worse neurologically, showing signs of increased intracranial pressure, or has signs of brainstem compression, surgery may be needed. One example is cerebellar hemorrhage, where a surgical evacuation through a craniotomy might be recommended. For intracranial aneurysms, the goal of surgery is to prevent bleeding in an unruptured aneurysm, or stop further bleeding in one that has already ruptured. This can be done by clipping the aneurysm's neck, tying it off, or reinforcing it with a wrap. Nowadays, we also see endovascular approaches, using coils, liquid agents, or a stent-like mesh to cut off blood flow to the aneurysm. The choice depends on the patient, the aneurysm's size and shape, and the surgeon's expertise. Complications after surgery can include disorientation, amnesia, Korsakoff syndrome, embolization, rupture, artery occlusion, fluid and electrolyte problems, gastrointestinal bleeding, or allergic reactions. Nursing process for the patient with a hemorrhagic stroke assessment. When you get this patient, you're doing a complete neuro exam, checking level of consciousness, pupil reactions, motor and sensory function, cranial nerves, speech, and vision. Look for headache, neck stiffness, or anything else that screams neuro change. The biggest red flag? A change in level of consciousness. Sometimes the earliest sign things are going south. Even subtle signs like drowsiness or slightly slurred speech matter. Nursing diagnoses might include risk for ineffective tissue perfusion related to bleeding or vasospasm, anxiety related to illness or activity restrictions, collaborative problems and potential complications, vasospasm, seizures, hydrocephalus, rebleeding, low sodium, also called hyponatremia. Planning and goals. We want improved cerebral tissue perfusion, less anxiety, and no complications. Nursing interventions. Optimizing cerebral tissue perfusion. Hourly checks on neurostatus, blood pressure, pulse, pupils, motor function, and respiratory status. Report any changes immediately. Aneurysm precautions. Bed rest in a quiet environment, head of bed up 30 to 45 degrees, no sudden straining, no valsalva, no neck twisting, no holding breath, and definitely no pushing yourself up suddenly. Dim lights help with photophobia. Stool softeners prevent constipation. Use compression devices and monitor for deep vein thrombosis. Relieving anxiety. Keep stimulation low, explain the restrictions, keep the patient and family informed, and give reassurance. Monitoring and managing potential complications. Vasospasm. Watch for headache, decreased responsiveness, aphasia, or partial paralysis. Prevention includes the calcium channel blocker nimodipine and sometimes fluid volume expanders. Seizures. Keep seizure precautions in place and treat with medication if they occur. Hydrocephalus. This can be acute, subacute, or delayed. Acute cases may require a ventriculostomy drain. Delayed cases may need a ventriculoperitoneal shunt. Rebleeding, most likely in the first 2 to 12 hours after the initial bleed. Watch for sudden headache, nausea, vomiting, decreased level of consciousness, or new neurodeficits. Low sodium hyponatremia, common after subarachnoid hemorrhage. Check labs often. If the sodium stays low for more than 24 hours, think about SIADH or cerebral salt wasting syndrome. Treatment often includes intravenous hypertonic 3% saline. Promoting home, community-based, and transitional care. Educate the patient and family about what happened, what the restrictions mean, and what to watch for. Prepare them for rehab if needed, teach use of assistive devices, and recommend home modifications for safety. During transitional care, reinforce the importance of follow-ups, risk factor control, and home health visits if needed. Evaluation: what success looks like. Neurologic status and vital signs stable. Alert and oriented, speech clear, cognition stable. Equal strength and sensation in all extremities. No complications like vasospasm, seizures, or rebleeding. Anxiety reduced. Patient understands aneurysm precautions. That's your overview of hemorrhagic stroke. From what it is, to how we treat it, to how we keep our patients safe after the fact.